Değerli katılımcılar, sayın hocalarım, kıymetli meslektaşlarım, bugün Doktor Azin Parsa bizimle beraber. Eee, Kendisini sizlere takdim edeyim. Let me introduce Dr. Parsa. Dr. Parsa obtained his DDS degree from Geelong University of Medical Sciences. He is a graduate of King's College in London, where he received a Master of Science with merit. He also holds a PhD in oral and maxillofacial radiology from the Academic Center of Dentistry for Dentistry, Amsterdam, with research focus on the application of cone-beam computed tomography in bone quality assessment. And he attained a certificate with a MS degree from the University of North Carolina at Chapel Hill. Dr. Parsa was the representative of Netherlands in European Academy of Dental and Maxillofacial Radiology and a member of Research and Scientific Committee in ODMFR for 6 years. And currently, Dr. Parsa is a clinical associate professor in a Department of Oncology and Diagnostic Sciences in University of Maryland in United States of America. Welcome, Professor, again to our webinar.
Thank you very much, Dr. Alper, for introducing me, and thank you, the Society, for having me again, and Professor Orhan and Dr. Koksal for arranging this meeting. So let me share my screen first. Share screen, this one. Okay, so do you have the title of my presentation?
Yes.
Okay. Okay. So I've been many times to Turkey since I was a child, and recently for different congresses, and that was the last meeting. I think that was in 2019. If there are some friends who cut from the size, I do apologize. This is the photo that I had. And I still have 2 gifts actually in my office. So this is the 2nd Congress, your Congress. This is the 3rd one.
Yeah.
Yeah, so there I had very good memories there. So very active society.
Perfect.
Nice people and nice food, of course.
Yeah.
And I was all the time surprised that whenever we were in EADMFR or IADMFR, let's say the Turkish radiologists were the highest participants in every congresses. So again, thank you very much for having me here.
It's our pleasure.
Yes. Thank you. So we need your mobile phone. I tell you the code to go there and vote, because this is an interactive session. So without your participation, it will be like a boring lecture. And for icebreaker, I have a question here for you. Yeah. So
nice head.
yeah. So please type in this address, PO.
Just a second.
Yeah.
I will write it. We write it at our mobiles, right?
Yeah, for the address. When you type the address of the link, then type this one.
Just a second.
Okay, so we got one answer. So this gentleman is not Amitabh Bachchan or Shah Rukh Khan or Amir Khan.
Okay. Now, what was I able to? I think I was able to answer that.
So let me try that. So.
Response recorded. Okay. Well, we may also write this to chat part, I guess. Maybe it will be better and easier for participants to
Okay,
respond.
then I need to have, because that's okay. Like, for example, I can vote right now, but if you type the address, then you will have the answers available. So anyone in is not able to vote, please type in the chat box.
Yeah, considering the nature of this webinar, and it is a interactive one, so I think we need to, all of us need to write this pollev.com as in parsa 8110, I guess.
Okay.
Can you see how many responders are in the?
If I close it, result total is a 6.
Only me? 6?
6. Okay, 6.
No, 6 is not,
Yeah.
not the 21 attendance.
Okay. So for the other things, is there, let's say, differential diagnosis, and I don't see who said what, so I cannot check that. So don't be shy. Just type whatever you think.
Thank you.
Yeah, because I don't see the names. This is just,
Right.
I see just the result and the number of participants.
Okay.
Okay, so case 1.
Just a second.
Sure.
Before we start, I will write it in the WhatsApp group. Can I see the
Yeah, sure.
link again? There's a poll locked here. Response not accepted.
Oh. Yeah.
Just a second.
Yeah.
Poll. .com. Okay. Now, okay, it's done.
Okay. Okay.
Yes.
So case 1, 29-year-old male, swelling at the left side of the face. This was our recent patient, maybe a month ago. And this was the first pan that we had. And the resident or the student, I'm not sure who was taking care of the patient, thought that the position of the patient in the panoramic radiograph was not good. That's why we had this big deformity. So they sent back the patient to say, please make a better radiograph of that patient. And so this was the first one. And then the patient had some issues with the insurances. Actually, the patient didn't have any insurance. And in the US, without having insurance, it's not going to happen, the treatment. So we offered a free CBCT because that was a very, let's say, significant findings. So let me show you what we found in CBCT. Do you have it, the CBCT?
Yes.
Okay, so someone said in the chat, so that was, so here, so let me minimize it. If you go to the pan, we won't have that much different we had in this, the surgical construct pans compared to the pan. But if we check it out in the, let's say, axial view, I start from the teeth going inferiorly. So here in the left ramus, erosive changes, bone reaction, and even here, so it's almost the left side of the mandible anterior and half of the right side of the mandible. And if you check that in the coronal view, that's actually very nasty.
Yeah.
And then they said, okay, we have done the biopsy and the biopsy showed just inflammation. And I said, okay, just inflammation for this one is not possible. And then I check the biopsy site. If there is any sign of the biopsy, then you cannot imagine they biopsied just from this small area. It's like having a swimming pool and you want to have the water test and taking a drop or two. So, okay, this is a very big lesion. You can just simply dig in and extract as much as possible. They went for the second biopsy and we were waiting for the results. And I didn't know what should I expect, because if the patient doesn't have any insurance, no treatment. But if it turned out to be a type of malignancy, then the treatment can be free without any, let's say, the insurance. Okay, so no root resorption. So what is your diagnosis? You can be specific or you can go more in details, whatever you think.
But should we see the diagnosis names to choose the?
No, this is a free type, so you can type anything.
We type there.
Yeah. Osteosarcoma, the first answer.
Just a second. Yes. There was no root resorption, right?
No root resorption, yeah.
Okay.
Central giant cell granuloma, granuloma, or two different answers. Osteosarcoma, a lot of answers. Fibrous dysplasia. Okay, so I'm not going in details of all the answers, but something like fibrous dysplasia. We know that it's ground glass appearance normally, but it may have a lot of different variety. But this is not the case, of course, here, because we should have blending borders. If we have expansion in fibrous dysplasia, the shape of the bone will be preserved. Central giant cell granuloma can be expansile anterior mandible. Age is good for central giant cell granuloma, but here we have more aggressive behavior. Okay, someone said something in the chat box. That's think Turkish. Okay. So
yeah. For it's a call to attend for interactive cases. But Professor Ashut, should we all the time enter this link for every question, or just staying in the link will be enough?
This is just the one, but if you go to the next question, you don't see that, just refresh it. If you
refresh, okay.
Yeah.
Every time a question, we refresh this.
Okay. You refresh it, yeah.
Okay, yeah.
Okay, so that's good. So it turned out to be osteosarcoma, low-grade osteosarcoma. So somehow I was not happy with the patient because she was just 29 and osteosarcoma is not that common that age. But the only benefit for the patient, as it is recognized as a malignancy, then the surgery for the patient could be for free. Okay, so nice answers. 61-year-old female, incidental finding in CBCT. So the patient came to our school here for implants planning. I will share you first, sorry, the pen, but I don't remember where was the site, most probably posterior mandible for implant planning, but definitely you won't see the finding here, okay? So I will go to the volume. Okay. So this is the volume. Again, I can show you the reconstructed pan. Again, the area that we were in, actually, that was incidental finding, so we were not interested to see that. Again, cannot be seen here. So if we go to the volume, first I will give you a try. If you can catch it, that's big enough, I think. Then I can go and focusing on the volume. So I'm starting from the superior, going inferior. I think you got it. That's a big lesion here. So where it's located? Mainly, it locates in the sphenoid sinus. We have expansion. We have erosive changes. And here, even the base of the skull is eroded. Then go inferiorly, maybe erosive changes or thinning of the carotid artery, invading to the trigoid region, and then something hanging out to the nasopharynx. If we check that in the sagittal view, so there is a big mass here. The epicenter should be somewhere here, maybe within the sinus or not, but most probably within the sinus. And you can see here something hanging up to the hard palate. So that was a big lesion. So while I was writing the report, I didn't do any bone measurement because as a radiologist, you know, like me, that if they send it for the implant planning, sometimes they just focus on the region that they are interested. They want to see what is that, if they have enough bone or not. So I didn't write a specific amount or something about implant. I highlighted this finding I said something like urgent, but they should be aware not making the patient scared. And I called the resident, and then the patient was sent to the hospital, not the same day, but just for making an appointment. Okay, so I think that's what we needed from this one. Again, base of the skull is eroded, and there is a mass.
Yeah.
Yeah.
This is a perfect example for writing reports for people using CBCT without any responsibility. This is a perfect
Exactly,
example.
but you know, this country is a country of suing, so they can sue easily. So
Yeah.
if you miss,
Every country don't have that regulation,
yeah,
unfortunately.
because I was living many years in Netherlands. The people there, they were very calm, cool. They just used to come to you and talk. But unfortunately, here there are some even fake patients. They know that they have bad dentitions. They go to the dental officers. They ask for some treatments, cheap treatments that they know that it's not gonna work. For example, restoration on a big cavity, for example, and they go to the court and suing the dentist. So yeah, so the responsibility here is
This is
very high.
Yeah.
Okay, so just memorize the shape of the lesion. Okay.
From our mobiles, we write the this link again, which exists in the chat box. Okay, this one. Just a second. I write it as well.
Unfortunately, the previous ones stayed there still. But I can see the new answers. Nasopharyngeal, squamous cell carcinoma. Nasopharyngeal carcinoma, or should be a carcinoma. Granuloma. Aspergillosis. Good. Papilloma. dysplasia. I like the answers, but for the next one, I have to do something just removing the old answers.
Yeah.
Okay, so that was very good. Yeah, so in my differential diagnosis, I first talk about something like papilloma and then a malignancy like a squamous cell carcinoma arising from the sphenoid sinus. But the key point of this case is the mass was hanging from the sinus. Normally, squamous cell carcinoma, let's say, expand in all direction, and we don't have something like that hanging from the sinus to the heart palate. That was very good. So that was inverted papilloma. So the patient was dating the resident, the pros resident frequently. She said, I'm going to MRI, to biopsy. And then she came back after a few months after the surgery recovery, very happy and very appreciated. So he sent an email to all of us that I came back for my implant planning, and I really appreciate your finding. It saved my life. And you know, as a radiologist, this is the best price that you can get from your patient, no matter what was the differential diagnosis. They come back to the school again healthy. Good, good, good. So case 3. A 65-year-old male, left facial swelling, pain, and dental malocclusion, very limited opening associated with a sharp shooting pain for 3 days. After a couple of weeks, he noticed lump in his face. So first he had pain and then swelling in the face. And that's a case from North Carolina. So let's go to the constructed pan again. Okay, so the patient said left side. So here the focal trough is right on the spot. So it's not here error in the construction. So we see here something going on, okay? Personally, I like to go to the axial view all the time first, but I don't know what's your approach. So I start from here, going inferior. Zygomatic arch looks good. Okay, so it starts from here. Compare just the right condylar head with the left one. Expand it. Radiolucent lesion here. We don't see the internal trabeculation. Expansion. The borders are becoming eroded and fade. Here we don't see the borders clearly. Here, that's a very ill-defined here. I don't see here the border, just a hint of if there is a border here. Going to the ramus, I don't see anything here. It's all gone. Then to the almost finished at the mandibular foramen. Then checking in the coronal view from posterior going to anterior. And sagittal, let's just jump. That's a good view.
Yeah.
All eroded. Where is the border? No idea. All the time when I'm seeing this kind of CBCT, I would like to have a contrasted MRI, a contrasted CT at least, because our eyes are more familiar with the CT in that time. But unfortunately, that's what we have. Okay. Yeah. So let me Don't answer, please. So I want
Okay.
to do something. Oh, sorry, I clicked on that. I wanted to close it. So
Wow. That was shocking. We couldn't find it. No worry.
because I wanted to tell you later that I don't want to be mean to you. If I don't say the patient has a liver cancer, you won't say that it's a metastasis. So sorry. So
Okay,
let's
well.
see if I can refresh it or not.
But the borders of the lesion, they were so invasive. It felt like a carcinoma, but considering the region, it would be more other stuff. So yeah, metastasis fits very well.
Yeah.
I
So
always think about the metastasis. Yeah.
yeah, metastasis normally I've seen an anterior mandible, maxilla, or posterior
Yeah.
mandible where we have more neurovascular region. But in the condyle, personally, I didn't have any case like that. So let me close the PowerPoint and open it again. And if someone knows what should I do to have it refreshed, please let me know. I don't use Paul Everywhere that much.
Unfortunately, me neither.
Okay.
But we should ask and let them write in the chat box. Maybe. Yes.
Okay, see. No, that's still there. I close and open it again. Maybe I can go to poll everywhere.
Yeah.
Clear responses. There are clear responses. Okay. I hope that I cleared the responses. It says cleared. Okay, anyway, I cleared, I don't know. So let's go to the case 4.
Okay.
A 24-year-old male, unremarkable health history of trauma to the face resulting in bilateral nose fracture. So the patient had second-degree assault. So patient had a fight and someone just punched to his face. Reduction of bilateral nasal bone fractures 3 weeks ago. So patient had a surgery. Chief complaint, burning sensation in his plate, and patient reports having no issues regarding to his nose. So this is the pan, and again, I'm telling you the incidental finding cannot be seen here. So I will bring case 4.
This guy had a fist on his nose 5 weeks ago, right, doctor?
Yeah.
Okay.
Okay. So again, this is the CBCT of the patient. So I start from, let's say, superior frontal sinuses. So the incidental finding is not a fracture in the nasal bone, for example. Okay, so if you don't see any fracture, that's not proposed. Okay, so we just passed. Okay, the incidental finding is not this tiny guy here. Okay, so let's go to the chronal. You have it now, the incidental finding. That's not a small, but the density looks like the surrounding area. That's why it's difficult to catch. But if you see it once, you won't miss it again if the patient has this history with this surgery. Sagittal view, I start from one side to the other side. Okay, so let's go back. Where was the incidental finding? Any guess where it was? Then we can go back to the region that you suggested.
In the sagittal, maybe.
Where?
In the sagittal view, there was
Sagittal view, but okay, where?
two lines.
Oh, 2 lines. Yeah, 2 lines. That okay, 2 lines. Good, good, good. Maxillary sinus. So Dr. Alpert just helped you. Where was 2 lines?
Very interesting case indeed.
Thank you. Nasal septum. Yeah, in the sagittal view, it's difficult to say it was nasal septum or let's say in one of the nasal fossa. Good, so let's go back there. So this is the area. So the density is very close to the soft tissue. Yeah, that was here again. So when I was reading this report, reading this CBCT for the report, maybe I was lucky, but I was checking the airway because normally I go up and down first for the, let's say, space of the skull and spine, and the next round for the airway, maybe the TMJ. Maybe when I was checking the airway, I found, okay, there's something going on, but that's very smooth. Yeah. Okay, so you all saw that there is something there, okay? So refresh it. So don't answer, please. I do apologize. Slideshow. Let's go back here. Okay, here type and refresh it and type what was that? Here we have less answers.
Yeah, there's a small answer there, maybe.
Oh, drain. Okay, yeah, drain. That's not drain, but something like that, because when we have drain, it means that we have some pus or some CFS or something for going out. Tube, that's a specific type of the tube. And to be honest with you, I didn't know the name while I went to the patient's history and I checked the patient's procedure, and then I found they use that. So I'm not taking your time. That's called Doyle split.
Wow.
Doyle split. Okay, so this is not something that they just use in the US or some specific area. So when they do the surgery in the nose, specifically in the nose, they don't want to have the attachment. Then they use this splint. What's the, let's say, the indication of that? When do they remove it? Just ask your surgeon colleagues, okay? So I'm not good enough for that. So this is made of the silicone. That's why it's difficult to define in the region. And there is the tube that you saw is just this part of the dural splint.
Mm-hmm.
So now I'm sure that if you have a trauma case and post-op, if you see that, then you know that it's called Doyle split.
Doyle split. But it's really it's hard to distinguish it. If you don't see
Yeah,
the two lines,
exactly,
you can go
exactly.
easily.
Yeah, yeah.
Yeah.
But okay, that's not something important if we miss that.
Yeah.
But maybe if the patient just decline it and then move into the other region and then have it that for many years, then that's something we have to find it. Okay, case 5. Okay, 25-year-old male referred by his dentist for evaluation of possible cyst in 2-3 region. Oh, sorry, by the way, this is the American numbering. So international choose number 2 and 3 should be 1617 or 16, 17.
16 and 17, yeah.
16 and 17, yeah. Okay. Case 5. Okay, again, hand. There is a radiolucent lesion posterior right maxilla. Based on this one here, we have expansion. Then we can go to the axial view. So comparing right and left, we have thinning of the bone, radiolucent, erosion of the lamina dura, root resorption, not really, but extended to the tuberosity and to the sinus, a little bit to the sinus. If we check that here from posterior to the anterior, and that's not multilocular. We have some septae.
And some little resorption on the palatinal
Yeah,
root and
yeah.
epiphysis. Okay.
Yeah,
But not an aggressive one.
exactly. Yeah. And the buccal bone and the cortical bones are preserved by tin. Here, maybe erosion, here, maybe, if that's not volume averaging. Okay. So I close the PowerPoint to open it again. I'm so sorry. Again, please answer here. Just refresh it and answer.
So we take the link from the our chat part.
Yeah, just if you refresh the previous one.
And we use it. It writes the incidental finding, but it's the answer of this question.
Yeah, so that's clear responses.
Yeah.
Okay, so I cleared that. So that was very simple. I did. I had just to click on the beneath the same slide, not in the main PowerPoint. Okay, simple bone cyst.
The lamina duras existed as well, but one point there was an erosion.
Yeah,
there was
some area.
in
Yeah,
the
some,
yeah.
yeah. Microepidermoid carcinoma. Myxoma. Granuloma, giant cell.
Giant cell.
Okay, so that was tough. So even if I didn't have the right answer in my differential diagnosis, but I was thinking something benign rather than aggressive. So we have here the right answer. So that was a myxoma. Myxoma, as far as I know, they said, okay, the septate should be like that or that, but myxoma can be in all different types. So I remember in our residency course, if all of our answers were wrong, then we know that that's myxoma. So that was uh, biopsy proven, and that was odontogenic myxoma. The nice history, let's say, a story of this patient, he was using that, and he thought maybe that's the reason that he has a lesion there. So before having that patient, I had no idea what is that. There are different brands in different countries. Apparently, when I Googled, this brand is from UK, Jawline Me. This is just a piece of rubber. And here you can see key benefits: exercise your jawlines, reduce your double chin, tighten your facial
skin.
Yeah, so, and they cost, yeah, 40 pounds in the UK for a piece of rubber. What do they do? This is not the patient, okay? So I was allowed to share this photo because I took it from a website. So they just put it there and rub it a few times, I don't know, a few hours maybe per day, just to have a rectangular angle of the mandible and have a mannish, like man-like face. So
this is some kind of facial fitness or facial building. Like
exactly. We have bodybuilding here. They wanted to have facial building. So before that, I didn't know such a device is existing, but okay. The patient told us, you know, I was using that thing, so maybe that's the cause of that. I said, okay, it's better not to use that, but you don't get myxoma because of that.
Okay.
Yeah.
As a complication, we will remember, yeah. All right.
Okay, 69-year-old male swelling at the right side of the face. Okay, very obvious. Multilocular radiolucent lesion, posterior maxilla, very expansive. Even it reached the right molar teeth, lower molar. So maybe the patient is even biting on the bone here. We have the CVCT, okay? So we will check if there's any root resorption. Apparently not. Extended to where? Most probably to the eye, somewhere there. So it's very expansive. So let's go to the CVCT. Okay. So reconstructed pan won't be that much better than the pan we had. Okay, but now we see it's extended way superiorly. Again, as usual, let's start from axial view. Going inferiorly, there are some signs here. I don't see the lateral border. Again, very fade border.
And considerable expansion as well.
Yeah, exactly. So if we just consider the left side is like that, so the normal maxilla should be up to here.
There doesn't seem to be a periosteal reaction there, I guess.
Oh no, I don't see any
Yeah,
reaction. Yeah, you're right. Let's try it in coronal view. From triggered place going anteriorly, so it's just a start here.
Wow.
Yeah, mainly radiolucent, but there are a lot of septation. So extended, you can see it's almost reached to the nasal septum. And here almost reaching zygomatic arch. Okay. Inferior orbital rim is intact, but if they leave it like that, might have erosive changes there as well. And here you see it's almost to the occlusal surface of the lower teeth. Most probably even the gingiva is traumatized there. Okay, because the patient is in maximum occlusion. It means that he's all the time biting on it.
Yeah. Clinically, maybe there's an ulcer on the maxilla.
Yeah, but I think if the patient was worried about something like ulceration, he should be more worried about the expansion of the bone.
Yeah.
We never know the patient, okay? So let's clear the responses. Clear responses. Okay.
Yeah.
Ossifying fibroma. Fibrous dysplasia. Amyloblastoma.
Giant cell.
Giant cell.
But the patient had no systemic problems.
As far as we know, no.
Okay.
Yeah. Brown tumor. And that's a tough case, actually.
Mhm.
We didn't have the right answer yet, but something like this one, between benign malignant, I would like amyloblastoma, but that's not the case here. Okay, so someone says anything else? Still, we don't have the right answer.
No.
But this is the post-op, by the way. That was again odontogenic myxoma. So I put both myxoma after each other to show, okay, the previous one was actually very small, but they behave very different cases, and their appearance are very different from each other. So for me, myxoma is one of the tough differential diagnoses to have. Okay.
But considering the operation of myxoma, which is recommended like 1 centimeter away from the lesion, this is a very good post-op, I guess, because considering the borders, it was a very big one. He still has his eye and things like that.
But yeah, so but if they just left something there and in future recurrence, we have no idea. Yeah, you all know that there is a pros and cons if they have a big thick margin or not. Okay, I have a case of the recurrence. If we do have time, we go to that. Okay, this is a case that I like it, and we published that recently. We have a colleague here. He's not radiologist, but he was in general practice for 40 years. So he likes to write about these kind of cases. So he knows how to write to make the story of these findings. Okay, so 56-year-old male, history of a sleep apnea. Okay, incidental finding. At the beginning, looks very simple. Okay, so we have here the density looks like a metallic object having something like a wire.
Mm-hmm.
Okay, so think about it. We have a CVCT, so we can check the exact location. Let me clear the responses. Let me
Not an ossifying fibroma, I guess.
No. So this appearance is very common for a lot of pens that we have, but okay.
You're asking a hi, okay.
Yeah, yeah.
Hypoglossal nerve simulator. Simulator, not a simulator.
Any other guess?
A secret microphone, like.
Okay, let's check the CVCT. And if that's okay, just the person gave this answer, just write in the chat box and type me, I want to know her or him. Who said
Congratulations to our colleague.
Because that was the right answer. So who said that?
Okay.
I'm very proud of that colleague in Turkey.
Me too. Whose answer was it? Can we have our colleague?
The hypoglossal nerve. Who said hypoglossal nerve stimulator?
Maybe.
Don't be shy. Okay, if you don't want, that's okay, because
no, maybe
the
there
right
can
answer.
be a communication problem as well from that.
Okay, that's okay. That's okay. So
Umut.
that was hypoglossal nerve stimulator, and let's see what it looks in the. Then the first time I saw this, the pen, I thought the patient had something in the collar, some type of the jacket, something like that. But here, that's okay. There is something within the soft tissue within the neck, and volume rendering. So we have 3 coils. So let me just take it out. So we have 3 coils and let's say a wire, and wire is connected somewhere for giving the pulse. And the hint of this question,
Dr. Parsa,
yes,
the colleague of mine confessed that it was a cheat, unfortunately, because you said you published it. He looked from the internet, from PubMed.
That's okay. That's okay. But that was a smart.
He's my colleague, Mutseki.
I cannot call him.
He's in my team.
Yeah, because it's not a quiz, and that's not a cheating. That was already published. That was nice. So that was nice. I love it. And yeah, the hint was sleep apnea. Again, I went through the patient's record, and then they said the patient having a simulator just for. I'm not very sure about that. How does it work? But at least like something like pushing the tongue and not leaving the tongue at the airway, collapsing at the airway, just preventing the sleep apnea at the time, at the sleep. Good. So, but okay, for who didn't read the articles, you don't need to read the articles. So that was incidental finding. Case 7. Case 8. Incidental finding in the first man. Okay, this is the case I need your help actually. So the finding, the incidental finding, very obvious. Impacted tooth, we have a radiolucency superior to that, and the tooth appears to be displaced backward. And then we have a heterogeneous mass here, so it's hyperdense. A little bit expansion here, but it hasn't reached the canal. The canal is not displaced, but we have a CBCT. We can check from all this views. Okay, so pen again. Same thing, so we go to other views. Let's start with axial while we have everything here. Okay. Starting from the superior aspect, radiolucency, let's see if there is any expansion. Yeah, comparing to the right side, not severely, but it's expansile. Then it's reached to the crown of the tooth. And then here again, we have another radiolucency surrounding a hyperdense, and it's almost reached the cortical border. But if you notice, I don't know if you have the same resolution in your laptops or not, the density is not exactly like cortical bone. So like here, the cortical bone looks denser.
Dense is like the cortical bone you saying, right?
Yeah,
Okay.
it looks like, but still I can
You can identify the cortical bone.
I can identify.
Yeah,
There is a line there.
There's a line there. Okay.
Yeah. And in the coronal view, again, radiolucency, crown, then the rest. I think having the costume section is a good idea. So maybe it's continuous, or maybe there is a tiny border that we don't see that. Okay, now we have three issues. A radiolucency here. Considering the radiolucency here, we can say a mixed density lesion here, and having an impacted and displaced tooth. So I'm saying that I need your help because I really need your opinion, because this is the case I ask everyone that I know, because the biopsy is not complete for me. We have the biopsy, okay? But let me clear the responses. What is your differential diagnosis? Ameoblastic fibroadenoma is okay, but normally the age is very young patients. Fibrodentinoma. I don't know what is fibrodentinoma. Let me make a note, then I can search for that. What is that?
There can be two lesions happening together. They coincide, maybe.
Exactly. Yeah. So then let's make the question like that. I will tell you the biopsies that dentigerous cyst, that the answer that we have here. So just thinking of dentigerous cyst is that radiolucency in the posterior. What is the other entity? Let me clear the responses. So we have definitely the biopsy said dentigerous cyst. But what do you think about that entity? Is that something separate? Or
yeah.
So if that's separate, what is that? Because I don't know. I have some guess that if you tell me, I said which of them were my guess. fibrous dysplasia, if that's fibrous dysplasia, but that's very well defined here.
Yeah, you can differentiate the cortical bone from the
Yeah,
inside opacity, as
yeah,
you
normally,
mentioned.
yeah. And normally it's like a ground glass, but we have, say, anastosis.
It
That
doesn't
can,
look like a complex odontoma or something,
that's what one of my guess, maybe
because there
complex.
is no opacity resembling the tooth tissues,
Yeah,
like
complex
similar.
odontoma. Yeah. Okay, that's good. So let's go back. So here we said that was dentature cyst. Here, complex odontoma, actually, to my opinion, that's the highest possibility.
Mhm.
But why is this placed? First, we had dentature cyst or odontoma. We don't have the previous images. Then it could be easier to have a right answer.
Yeah.
When was the tooth displaced? Is that the type of the odontoma that they grows or not? So again, that's still at the level of the guess. Okay, but anyway, I liked your suggestion. Thank you very much for that. So I didn't know dentures with
With
with
what?
what. That's the post-op. That's I don't know how many weeks
Still,
after.
they couldn't take the opaque part as well.
Yeah,
It
yeah.
stays
Because
there.
exactly, because maybe I don't know. Maybe they thought that they may injure these tooths and then they have to extract these tooths. It's already reached the lamina dura. You are absolutely right. But luckily,
Oh.
this is the 3 years post-op. So
Hmm.
that was a very good healing. So I like 3 years post-op.
If this was a fibrous dysplasia and it was that interrupted, so it should maybe respond to this operation, maybe.
Oh, maybe. Yeah. And by the way, in the first case, which was osteosarcoma, someone said fibrous dysplasia. So we know that fibrous dysplasia, a lot of osteosarcoma can arise from fibrous dysplasia. So that was not the case there, but that was something close to the answer. Do we have time?
Yeah, we have plenty of this. Perfect.
Okay, because I prepared another 2 cases.
Perfect.
For the other case has 3 CBCT. So, okay, let's start with this case. 64-year-old male seen previously for periapical pathology, palatal root tooth number 3.
16, I guess.
Sorry, 16. Yeah, 16.
Or smaller. Okay.
Yeah, thank you. Okay, so, yeah, I remember the case. So the case came to North Carolina to the school. So the patient had a bad perio problem. So they took this PA. Okay, which is not related to our case here. This was the time that I was there, so 2021. Okay, so forget about the perio problem. Do you see any other lesion somewhere else? Just take a look in 1 or 2 minutes. Not the perio lesion, any other lesion. Because in the next question, I want to ask you in which quadrant.
Yes. Should they say the first one, second one, third one, and the fourth one?
Yeah, so first
Okay.
quadrant, second quadrant, yeah, third and fourth from the midline just dividing. Okay. Okay. Two. Okay. Good. Two. So there is a lesion here. The reason that I wanted to ask you, because you all said 2, which is correct. I went back to the patient history, and by the way, the time that they had the FMX, They had a pen, they had a full mass series, and we could see the border. But we have the CBCT as well. Then I went back to the patient history. That was there since 2018. So for 3 years, that's the problem from our colleagues. When they want to do the dental treatment, they just take a look at the teeth, the dentist. I'm not blaming all of them, but there are, unfortunately, everywhere there are lots. If the patient has an empty spot here, they just want to go for a crown. If the patient has financial possibility, going for implant. So they just left it like that because the patient was asymptomatic. Okay, so now CBCT. Okay. So we are not going to check the reconstructed pan. Let's see.
There's a limited field of view here.
Yeah. Which in that case, that was almost enough, but at least I think a single arch was good, not a limited field of view. Okay, so let's start from this is Tuesday, 11, 12, 13. Am I counting right? Yeah, 11, 12.
Yeah.
Okay. Not that much expansion, but we have expansion. Considering the lesion was there since 2018 for 3 years, so we don't say that's a very expansive. It had enough time for expansion. Nasopalatal duct, a part of that visible, but mainly not. The patient is not symmetrical, the lesion is not symmetrical around the nasopalatal duct, is extended somewhere from the midline, almost midline to the left, and checking in the coronal, expanded to the nasal cavity. Nasal cavity is thin, but not perforated. And in this kind of case, we check the teeth as well. No restorations, no endodontic treatment. These tooth has a perio problem, but if you take a look at the apex, I would say that's something separate that they reach to each other.
There's a bone existence between two
Okay.
licenses, yes.
Okay, so you're in agreement with me that this is something that they reach together because the patient has a lot of endoperio problem. And here, other sides, there is something, okay. For example, here as well, okay, but that's not related. So now thinking of the canine, we have the loss of the lamina dura somewhere, but the apex is not at the epicenter. Lateral and canine are all there. Root resorption, I don't think so. It's a sagittal, no, not at all. Okay, so
is there a disturbance in the palatinal cortical?
I will bring it again. Here. Yeah.
Is it, I mean, secondarily infected or something?
Might be. Again, we can have a discussion about this case. Okay. Your responses, keratocyst, that's a good guess. Odontogenic keratocyst, OKC. I put OKC in my differential diagnosis. Odontogenic, and the other is giant cell. Odontogenic cyst, or that was odontogenic cyst. Tumor, bone tumor. fibroma. Okay, so again, like the previous one, I need your help. So that was the report. They said periradicular cyst with focal abscess, the left anterior maxilla. As I'm not good in the histopathology, that was done by a histopathologist in North Carolina with more than 50 years experience, actually. So I asked our young colleague here, which is very good, to read the description. I said, okay, that's very vague. So we can see that's a type of the cyst. And I asked him, what if that was an OKC, for example? He said, we won't miss OKC because of the cheesy material. We can see that easily. There are some hints that they didn't find in this description for OKC. I said, what about nasopalatine duct cyst? We know that normally nasopalatine duct cyst is more symmetrical, but maybe that's a rare appearance of that. And he said, if that's the case, we should have neurovascular material in our biopsy, which they didn't report. So, but if, I don't know if by periradicular, they mean just a radicular cyst. But if that's the case, then but the teeth were intact. So, but I don't know if they had a trauma or something, but normally again, radicular cyst is more expensive. So it's still, I'm not convinced with that biopsy. Then while I was, because I was preparing these, the cases, the interesting cases for you, then same time I asked my colleague, the pathologist, and he said they should have done the surgery by now. So contact them. They should have the second biopsy after removing this the lesion.
Yeah, the final one.
Exactly. And similar thing, the only thing that they added was vegetable. They said there were some foods and they found that the vegetable was within the lesion. It's okay, that's not very helpful. It's a little bit disgusting, but again, their conclusion was something like periodical cyst with focal abscess and having hint of the vegetable. So that was the answer of this case. Case 10. If you said we have time, I think it will take.
Yeah, we have lots of time, and I would like to make an addition, just to remind an old friend called globulomaxillary cyst. Remember our old friend, which doesn't exist anymore.
Okay.
Maybe it used to be something like that. Now
Yeah.
looks like a keratosis. We never know, because you said in 2018 it existed. Maybe it existed before, and before that without
Maybe.
any symptoms. Yeah, just to remind our old friend,
Yeah,
globulomaxillary cyst.
yeah, yeah, you're right.
Okay.
Yeah, yeah. Okay, so 72-year-old. Okay, so the patient said in 2000s-ish, something like that. The dentist thought there is a cyst. Okay, so let's make the story short on this one. That's in 2019. The patient had an endodontic treatment here. There is a lesion that we have a CBCT that we can see that. But the patient came to us in 2019. But the story started many years before that. I don't know how many years because they were not very specific. I think something like 2010. The patient can recall that first they saw radiolucency, they did the endo, and then after that they thought that's a cyst and they removed the cyst. What was the biopsy? No idea. Which type of the cyst? No idea. Maybe just an endodontist did just minor surgery. So I have no idea about it. So let's pull up the CBCT of this one. Sorry, it's loading. It takes 30 seconds, most probably. Let's me make sure if that's okay. Yeah. Okay. So we were talking about anterior maxilla. And when was that? That was for, oh, by the way, 410, it means here April. Okay, so here that they put the months first. So 10th of April.
Okay.
And here is taken 6 months after the PAN. So anterior maxilla. Tooth number 113 has endo, radiolucent lesion, no cortication.
Yeah, goes everywhere.
Yeah, exactly. Here, ill-defined, partially ill-defined, we have to say. Here, I don't see the cortical border of the hard palates reaching the adjacent teeth. So now we have it at least for these 4 teeth involved in the lesion.
6 months after, right?
6 months after, but that was the PAN. So we may have a bigger lesion that was superimposed. Okay. So in 6 months, but here there might be a bigger lesion that we don't see that. That's maybe. Okay, so this was the CBCT that we checked. So let's refresh it. And then tell me what you think about it. Squamous cell carcinoma. There might be 2 options: having squamous cell carcinoma or squamous cell carcinoma arising from the cyst that they left. We don't know.
Mm-hmm. It may arise also from inside the bone as well.
Inside the bone, but the patient was talking about from a cyst about 2010. That's why I thought there was something going on in 2010. Okay. Maybe another lesion, or maybe a squamous cell carcinoma arising that, or as you said, maybe just having a primary squamous cell carcinoma. But that's not the case, but that's something that we can put it in differential diagnosis. And if you want to change your opinion, you can just remove your answer and type a new answer. There's, I think, the trash bin in your, the refresh something in under the answer. Infected cysts. Okay, inflamed radicular cyst, for example. But that won't be that much ill-defined, I believe. Okay. So that turned to be amyloblastoma. Again, we don't know if that was there from 2010, which is rare. I don't know, because this is benign aggressive, but we don't know because we don't have any biopsy at that time. So that's the post-op. So something like a month after that CBCT, so they removed it. Okay. Mm-hmm. Now we have another 2 CBCT follow-up. This is less than 2 years, so almost 1 year and 3 months after the treatment. So we don't have any post-op immediately after the treatment. So let's pull up the second one.
The first images from were from 2019, I guess.
Yeah,
2 years before the other ones.
The other ones, yeah, this one 2019.
19. Okay.
Yeah,
Two years
CBC, yeah,
after. Okay.
yeah, CBCT done 19.
Yeah.
Treatment again 19, and now it's 2021. Okay. I don't know if the patient had a symptom or they just want to have a follow-up. We know that when they said if there is any sign of the recurrence, first of all, we would say, do you have a previous one that we can superimpose on each other? Because if they remove it, we shouldn't have any growth. If they don't have it, then we should just check the borders.
Mhm.
I expect after 2 years after the surgery, I expect to see cortical borders.
Uh-huh.
Here, I don't expect to see anything because they remove it. Sometimes we have some periosteal somewhere reaction, which is not bad all the time because we say periosteal reaction is sign of osteomyelitis or osteosarcoma. But in the case of the surgery, that's a sign of having a newly born form. So that's not bad case in all the cases. But just based on this one, having no other CBCT before that for superimposition. Let me refresh that. Do you expect to have recurrence or not? Just say yes or no, please. Yes. Okay. And they did the biopsy after this one. Why? Because based on the borders, let me show you again. I didn't like these holes because in the surgery, they won't leave it like that. They just cut everything. So why we have 2 holes here? And the other side, some side here, it's not corticated.
Yeah.
Yeah. But the final diagnosis, there is no evidence of residual ameloblastoma, which I don't believe that. There might be bad sites for biopsy. They may just did the biopsy superficial. Why there is a big hole in the patient's mouth, I don't know why they hesitate going deeply and take the, let's say, biopsy in 4 different sites. And then after that, 2021, the second CBCT, the third CBCT, sorry.
Mhm.
So this one was in January 2021.
Mhm.
This is in October.
October.
So like in 9 months, because they told the patient, you don't have any signs of recurrence. Where are 2 holes? They are gone.
Yeah.
Why? Because it got bigger and bigger. So even without any superimposition, you could say that that's obvious. Recurrence is obvious. So they could have a, let's say, better surgery rather than leaving that for 9 months, having that much bigger than just cutting all this area.
Yeah.
Then that's difficult for prosthesis. And you know that the patient should go through a very big procedure, speech therapy. The patient cannot properly eat, the patient cannot properly speak with that. And I did the superimposition, and that's the difficulty of radiologists. While we do the superimposition, we play with the contrast and brightness. We just bring the first and the second one to show the borders. But how you can want to show to the surgeon that they are superimposed. Normally, I do like that. After the superimposition, You see here two, let's say, shades on each other. So yes,
Dr. Parsa, for our young colleagues, this is a very good technique. Would you explain a little bit more how you do that?
Yeah. Okay, so superimposition means that when you have two identical objects, two identical scans, for example, one before the surgery, one after the surgery, or you have done orthogontic treatment, you want to see the changes. So you bring both, let's say, scans matched on each other, you superimpose on each other, but you should have identical area. For example, if the patient is 8 years old, second one is 10 years old, you know that you expect a lot of growth. There, you don't have identical region for matching. But the patient is adult here. It means that if there is something going on anterior maxilla, the frontal bone is like that. Let's say the zygoma is like that. So based on the zygoma and frontal bone, we bring two region matched on each other or we superimpose on each other. There are three different ways: surface-based superimposition just based on the surface, or voxel-based. It means that you just tell the device, like in vivo, for example, here, based on the gray values of the region, they superimpose the region, the scans. But you said, okay, I want this area based on the gray value superimposition. Or the third one, which is good, I like it, is point-based. It's something like manually. You have two volumes side by side. You go to the, for example, mental foramen. Mandible is not a good area. Maxilla is better. You go for infraorbital foramen, for example. Click on that. Going to the second, click that. Going to the nasion, click on that in the first scan. Nasion, click on the second point. If you select something like 5 points, then the software will match two scans based on the identical region that you selected.
Yeah,
was that good enough? Okay.
Yeah, perfect.
Thank you. So now we have, you see the maxilla, the sinuses are superimposed on each other. If we have a shade here, that's okay because mandible might be in a different position. But here the blue arrows is showing the border of this scan in January, while this is showing the border in October, which means that the lesion grows a lot. Here in the axial view, even we see that there is a soft tissue invading the nasal cavity. So that's very bad for the patient, of course. Okay, so for now, our young colleagues, this shows that how our role can be important. You don't expect other specialists or dentists be more precise like you because this is our job, but we may save a lot of lives. Like the first case, inverted papilloma. That's not life-threatening, but that's already in the base of the skull. Or I had a case that was an endo case for one of the anterior teeth, but then I saw a very ill-defined radiolucency in the one side of the hard palate. Again, I wrote my report recommending for biopsy, but I didn't leave it like that. Again, after 2 weeks, I called the practice. I did my job, so I was not responsible for that, but I called the practice for making sure that they have seen the report. As usual, this assistants or the secretaries, they said, okay, doctor is busy, you are a radiologist, okay, what do you want to say? I just scared them that way, tell the doctor, the problem of the patient might be something more than losing a tooth. But I cannot say life-threatening or something. We are not allowed to talk like that. We cannot panic. And the problem in our reports, if we are at the school, if the patient is at a school, they have a portal. They have an access to all of our reports.
All the reports. Wow.
Yeah. So they may see the reports before the doctor talk to them. So if we see something like you said, for example, squamous cell carcinoma, which might be the case here, we don't name that, because patient after seeing that will start Googling what's the squamous cell carcinoma.
Yeah.
Maybe having a heart attack right now, maybe going to suicide.
Yeah.
In the country that a lot of people, they have gone suicide, that's it. So we have make story in that way, based on the, for example, aggressive behavior of the lesion. Biopsy is recommended, or we may say biopsy recommended to rule out any type of malignancy. Something like that. Of course, we are not sure, but something like giving a relief to the patient. Okay, so the last one. Çok teşekkür ederim. This again, my colleague.
Biz teşekkür ederiz. We thank you.
Okay. Yeah, I remember these colleagues from Turkey. That was sightseeing. I think this is the name of the area that we went for sightseeing. Yeah.
Perge, yes.
So these are this was colleague from Canada. This is me, Ruben, a very good friend, very knowledgeable colleague from Belgium. Ingrid, I think you know her. She, because she speaks in Turkish. So okay.
Yes.
Okay. So she has a very good collaboration with you guys. And unfortunately, I don't remember the name. These guys, they took us for, you know the name?
Yeah, Oz, I think, one on the right.
Okay. Yeah, so they took us with their own cars for sightseeing. So as I said, as usual, I like Turkish friends, colleague, I have very good friends there, and I hope to see you all again there. If there is any, so you are the moderator, you have to ask if there's any questions.
No. Yeah, maybe there may be questions. We can take questions if you have time, Dr. Parsa.
I have time, yeah. So I made an interactive session.
Yeah.
If they have questions, they could ask during the session, but I have time.
So, any questions? Soru almak için bekliyoruz sevgili meslektaşlarım, katılımcılar.
That's fair if there's no question, because we are not talking about any let's say research. And this is, I think, the first time or second time that I'm doing case presentation. All the time I was talking about my CBCT findings technology, because I did my PhD for CBCT and gray values. So I was mainly talking about bone density, microstructures, and CBCT. But as far as I found some good cases, I really wanted to share with you guys.
Thank you very much, dear doctor. On behalf of my colleagues, I congratulate and thank you for this beautiful presentation and very interesting and informative cases, which also gives us a broad perspective of what's going on in this field of view, what can we find in this field of view. Thank you very much. So considering the, I think the time and we finished our cases, I think it's time to end the webinar, I guess. So hope to see you soon, and maybe next year or this year in Turkey as well. You're always welcome.
My pleasure. My pleasure.
Yes.
Okay, take care. Thank you.
Bye bye. Değerli katılımcılar, webinarımıza burada son bulmakta. Bir dahaki webinarımızda görüşmek üzere. İyi günler diliyorum.